First, the anatomy of a blood clot, then who is at risk, spotting the silent threat, solving the medical mystery, treating and targeting DVT, and finally, preventing the next clot.
Okay, Section 1, Anatomy of a blood clot.
So let's talk about Virchow's triad. This is essentially the fundamental root cause of all deep venous thrombosis. Think of it like the perfect storm for a clot. For DVT to occur, you generally need a combination of 3 critical factors. First up, stasis. That's immobility or just really sluggish blood flow. Second is endothelial injury, which just means damage to the inner lining of the blood vessel itself. And third, hypercoagulability. That's a state where your blood is just, well, way more prone to clotting than it should be. If you've got these 3 things overlapping, a clot is almost inevitable.
Now, let's rapid fire through the anatomical basics. By definition, a DVT is a semi-solid coagulum just sitting there in the deep venous system. Most commonly, these clots are forming in the calf, specifically the soleal veins of the lower limbs. But, and this is a really crucial point, while those calf veins are the most common site, it's actually the proximal veins, like the iliofemoral veins higher up in the leg, that pose the absolute highest, deadliest risk for a pulmonary embolism. That's when the clot breaks off and travels right to the lungs. And hey, it's not just a lower limb issue. Upper extremity DVT can absolutely occur too. It often presents as Paget-Schroeder disease. That's an axillary vein thrombosis we typically see in people doing heavy, repetitive arm movements. Think weightlifters or javelin throwers.
Moving on to Section 2. Who is at risk?
You might actually be surprised to learn that the absolute #1 single most important risk factor for DVT is simply hospital admission, whether it's for medical or surgical treatment. Why is that? Well, trauma or surgery causes your body to release massive quantities of tissue factor. This drastically increases the adhesiveness of your platelets, making clots form super easily while you're just lying there completely immobile in a hospital bed. Other major risks include post-bariatric surgery, which is actually a leading cause of death in those first 30 days post-op. Pregnancy and high estrogen therapies also create that hypercoagulable state we talked about. Plus, all cancers are considered prothrombotic. Now on the congenital side, the most common prothrombotic state is the factor V Leiden mutation. And get this, anatomically, we even see something called May-Thurner syndrome, which is wild. It's where the right iliac artery literally physically presses down on the left iliac vein, crushing it and causing a clot.
And that brings us to a massive risk multiplier, having a previous DVT history. Take tennis legend Serena Williams, for example. She had a minor trauma a few years back that led to a DVT. Then, years later, when she was pregnant, which, as we just learned, is a prothrombotic state, she developed a recurrent DVT in the exact same limb. This perfectly proves that a previous history of DVT is just an incredibly strong predictor of future clots. Once you've had one, your risk absolutely skyrockets. Yeah, even if you're a world-class elite athlete. Section 3. Spotting the silent threat. Here's the truly terrifying clinical reality. The vast majority of calf DVTs are completely asymptomatic. The patient feels absolutely nothing. Because of this, doctors have to maintain a really high degree of suspicion. Now, you might have heard of older physical exams like Homan's sign. That's where you flex the knee and dorsiflex the foot to feel for calf resistance. Or Moses sign, where you squeeze the calf to check for pain. But listen closely, here's what you need to take away from this. These clinical signs have incredibly low sensitivity. In fact, they shouldn't even be routinely checked anymore. Why? Because squeezing that calf can actually dislodge the silent clot and cause a fatal pulmonary embolism. No way you want to risk that. Also, don't confuse DVT with superficial thrombophlebitis. That's just inflammation and a clot in the surface veins, often showing up as a painful cord-like vein after a routine IV line complication. It's painful, sure, but it's not the deep, silent killer we're hunting. Now, when DVT isn't silent, it usually presents in 2 starkly contrasting ways. On one hand, we have phlegmasia cerulea dolens, which literally translates to a painful blue limb. This happens when the major axial veins and the collateral veins are completely thrombosed or blocked up, which can rapidly progress to venous gangrene. Pretty scary stuff. On the other hand, we have phlegmasia alba dolens, a painful white limb. This one is sometimes called milk leg because it's so commonly seen in pregnancy. Here, the major veins are blocked, but the collaterals are spared, which leaves the limb white and painful, but crucially not blue. Moving right along to Section 4, solving the medical mystery. So, how do doctors figure this out? They use the Wells criteria. This is a vital mathematical scoring system used to determine a patient's exact probability of having a DVT before a doctor ever even touches an ultrasound wand.
It looks at a whole bunch of various risk factors. For instance, intravenous drug use, that adds points to the score. But cleverly, if an alternative diagnosis seems more likely than DVT, points are actually subtracted. This mathematical model quickly categorizes the patient into low, moderate, or high risk. Once a patient is categorized as at risk, we scan. But in diagnostics, there's a massive difference between what's considered best and what's actually practical. For DVT, the so-called gold standard investigation is venography, and for a pulmonary embolism, it's pulmonary angiography. But here's the catch. These gold standards are highly invasive, so in reality, they're rarely done. Instead, the standard investigation of choice for DVT is a duplex scan, which combines color Doppler and B-mode ultrasound. And for pulmonary embolism, the investigation of choice is a much safer CT angiography. Okay, there's also a very common blood test you should know about called the D-dimer test, but honestly, it's kind of tricky. A negative D-dimer test has a high negative predictive value, which means it successfully rules out DVT. If it's negative, you're safe. Boom, done. However, if you've recently had trauma or surgery, your D-dimer is going to naturally be elevated anyway. So a positive result post-surgery has to be taken with a huge grain of salt. It might just be a false positive from the surgical trauma itself, not a clot.
Section 5, Treating and Targeting DVT. The absolute foundation of DVT treatment is anticoagulation, essentially thinning the blood. But it has to be done in a very specific two-step chemical bridge over 5 days. Step 1. We start the patient on low molecular weight heparin plus an oral drug called warfarin for the first 5 days. Step 2. After those 5 days, we drop the heparin and continue with just the warfarin. Now you might be wondering why the overlap. Well, warfarin actually causes a rapid fall in your body's natural anti-clotting proteins, specifically proteins C and S, much earlier than it affects other factors. This means that for the first few days, warfarin actually induces a dangerous transient prothrombotic state. Yeah, it temporarily makes you clot more. So we absolutely must use the heparin as a protective cover until the warfarin fully kicks in and does its job. Now, when a patient is on warfarin, they require intense monitoring using a metric called INR, or International Normalized Ratio. To put it simply, this is a standardized measurement comparing a patient's prothrombin time, or their clotting speed, against a normal control. We're basically measuring exactly how thin the blood is to ensure it stops the clot from growing without causing fatal internal bleeding. It's a really delicate balance. And that magic number? 2 to 3. That is the exact target INR range required to manage a DVT. We want the INR raised just enough to hinder coagulation, so the clot doesn't expand or break off, but not so high that the patient spontaneously bleeds out. But let's contrast that target with this really vital number, 1.4. This is the absolute maximum permissible INR if a DVT patient on warfarin suddenly needs emergency surgery. Think about it. Imagine a patient on warfarin comes rushing into the ER with a bursting appendix. If their INR is 1.4 or lower, the anesthesiologist will clear them for emergency surgery. But if their INR is, say, 2.5, they'll bleed excessively on the operating table. In that critical life or death moment, doctors have to quickly push prothrombin factor concentrates, or fresh frozen plasma, to rapidly bring that INR down so they can operate safely. Beyond basic anticoagulants, there are some pretty advanced interventions. For severe proximal DVTs, the ATTRACT trial actually showed we can use catheter-induced thrombolysis. This is literally injecting clot-busting drugs directly into the vein to dissolve the block and reduce the risk of long-term post-thrombotic syndrome. Real game changer. We also now have NOACs, novel oral anticoagulants like rivaroxaban or apixaban. These are amazing because unlike warfarin, they require zero routine INR monitoring, and they were highly utilized during the prothrombotic waves of COVID-19. Finally, if a patient absolutely cannot take blood thinners, let's say they just had a massive brain bleed, surgeons can install an IVC filter. This acts as a physical sieve right in the inferior vena cava, catching clots before they ever reach the lungs. But beware, it carries a risk of catastrophic IVC blockade, where massive clots clog the filter entirely, crashing the patient's blood pressure and dropping their jugular venous pressure dramatically. Which brings us to our final section, number 6, preventing the next clot. When it comes to DVT prophylaxis, especially in a hospital setting, chemical prevention is simply the best route. Pharmacological prophylaxis using low molecular weight heparin is far, far superior to merely using mechanical methods alone. That said, mechanical methods are still totally essential. But we have to bust a major myth right here. True early ambulation requires getting the patient out of bed and actually walking. Simply sitting a patient up from a lying position is actually one of the worst things you can do, because it further increases stasis.
To mechanically prevent that stasis while patients are bedridden, hospitals use pneumatic compression stockings. These periodically inflate and squeeze the legs, artificially keeping the blood moving when the patient can't. All right, we've covered the hidden anatomy, the surprising hospital risks, the clinical scoring, the chemical balancing acts, and the critical methods of prevention. So, bringing it all back to where we started, knowing these silent, potentially fatal risks that can pool in your veins simply from immobility, I'll leave you with this provocative question. Are you going to stay seated on your next long flight? Keep that blood moving and stay curious. Thanks so much for joining me on this explainer.